Dear colleagues, hi everyone, how are you? I hope you are well and welcome to this EUROPREV webinar. I'm very happy to have with me our speakers of tonight's webinar. So I will start presenting them. We have with us Professor Barbara Farrell. She is assistant professor in the Department of Family Medicine, University of Ottawa, and she's also senior investigator in the Briere Research Institute. And her field of research is mainly around the topic of deprescribing, and she has developed a lot of work in this field, deprescribing guidelines, and she's one of the founders of the deprescribing.org platform or website. Hi, Barbara. Welcome to this webinar. How are you?
I'm good. Thank you, Carlos, for inviting me. And I just realized that my name looks like it's deprescribing.org research team, but it's actually Barb Farrell.
Okay. Okay. Otherwise, did I mention your place of work correctly?
Yes, that's correct. And I should also say that clinically, I work as a pharmacist in our geriatric day hospital 2 days a week. And so I see a lot of older people with cognition and mobility problems, and we do a lot of deprescribing.
Okay, okay. And how was your day today, or how is it being? Because you are speaking with us from Ottawa, and it's the beginning of the afternoon, isn't it?
Yes, it's 3 o'clock here, so it's just near the end of my day. And I spent the morning in the day hospital and saw 2 patients and another patient earlier this afternoon who were actually reducing and stopping his benzodiazepine. So it was quite timely.
Wow. Okay. Okay. Thank you. And now our other speaker, we have with us also Professor Lisa McCarthy. She is associate professor in the University of Toronto. She does and is clinical pharmacy research related to drug safety, health service research. Lisa, welcome. Thank you for being here. How are you?
I'm good. Thank you very much. Thank you very much for the opportunity to be here today. And hi, everyone.
Okay. And your day, how was it? I believe you are speaking with us from Boston.
So yeah, I'm actually a Canadian in Boston today. So normally I'm based in Toronto, Ontario. So not a couple of hours away from Barb, but see her frequently online. And today in Boston for an event tomorrow. So I'm glad that we were able to do this with you today.
Okay, okay. And thank you both for accepting our invitation to be with us. So we have a lot of colleagues already attending our webinar and already saying hello. I will share with you some of their messages. For example, Maria Bacola, hello from Ioannina, Greece. Jane, hi Carlos, hello everyone from Germany. Rosario Falanga, hello from Italy. Jose Bueno from Spain, looking forward to enjoying a new EUROPREV webinar. Thank you, Jose. Carolina, hello from Lisbon. Anna Cristina, hello from Ukraine. Hi, Anna, how are you? Mariana Leitão, hello, good night from Portugal. Dara Punozevac, greetings from Serbia. Hi, Dara, and I'm sorry if I don't pronounce your name correctly. Sometimes it's difficult in these international events. Gergana Atanasova, greetings from Bulgaria. So, colleagues from many countries. Wow.
Yeah, that's awesome.
That's amazing.
Okay, and so many colleagues interested in deprescription. Barbara, the field is yours, please. Let's begin.
Sure. So I will start by sharing a screen. And just can everyone see this?
Yes. Okay.
Perfect. So Carlos has already talked about the fact that we're going to talk about deprescribing in older people. And we started with the discussion about benzodiazepines and realize we're going to go a little beyond that today in our discussion. And of course, I'm trying to move this forward. There we go. So you've already met both of us. Just by way of additional introduction for myself, I got interested in benzodiazepine use back in 1993 when I was in my doctor of pharmacy program at the University of Toronto, and was seeing patients in an elder care clinic who we were stopping their benzodiazepines and they felt so much better. And I did a lot of research around that at the time, and that's just really continued over, gosh, I guess it's now 30 years that I've been interested in the topic. And so I'm really happy today to share my experience, not just with benzodiazepine use, but also deprescribing in general with our patients. So Lisa, is there anything you want to add?
Yeah, I think one thing I haven't said yet is that I am also a pharmacist and a clinician scientist living in Ontario, Canada. And in my clinical life, I've actually practiced across a variety of different care settings, but I'm actually currently practicing for the last 2 years in acute care. So trying to find those deprescribing opportunities for older adults on a medicine unit in one of Canada's largest and its fastest growing hospitals, which I'll talk a little bit more about kind of that care setting. In terms of my research hat, I get really excited when I can study people, processes, and resources where we're bringing evidence-based care to reality. And a lot of the time, clinically and research-wise, is spent really working to make sure that people are receiving the medicines that they need, no less and no more than that. And so I've been honored to work with Barb as part of the deprescribing.org team for nearly 10 years. So really excited to talk with you all today and share some of our experiences from different care settings.
Excellent, thanks, Lisa. So we have our disclosure slide here. We both have some honoraria for different presentations and chapters and such that we've written. We both have support from the Centers for Learning, Research and Innovation in Long-Term Care here in Ontario. Lisa recently actually got a large CIHR grant to look at the potential for deprescribing of hypoglycemic medications in long-term care. So that may come up during our discussion, and other ways we've both indicated our employers here for you. So in terms of objectives today, what we thought we would do is share our own experiences with deprescribing across different care settings, and not just with benzodiazepines, as I mentioned, but and then also looking in, in primary care, hospital care, our geriatric day hospital, long-term care, and even community pharmacy. We're going to describe a lot of the approaches that are based on our deprescribing.org evidence work using real patient cases. And we hope to make it interactive so that we can have some spots to pause for discussion. So I'm going to start first by telling you about a patient case. So this is actually a real patient from our geriatric day hospital from a series of 8 case reports that we published actually about 10 years ago. But these case reports, because they deal with polypharmacy, are still applicable now. And I will include a link in the chat at some point during the discussion so that you can go to our website and get access to all 8 of those case reports. So in this particular case, we had a 93-year-old man who was referred to the day hospital because of falls, little confusion, but mainly like daytime fatigue and low energy and just, not feeling well. And I was asked to consult with him about the potential to reduce his lorazepam. And the kinds of questions that come up from our physicians, from our medical residents, our medical students, our pharmacy students, our nursing group is, how do we get people to buy into the idea of reducing their benzodiazepine? And then once they've sort of agreed, how fast can we actually taper the drug? By what amounts? What's going to happen to their sleep? What will there be any withdrawal reactions? What will they be? How severe will they be? When will they happen? How do I handle this? And then because we're kind of a referral center for primary care doctors who want help with their older patients, the question then is, how do we get the buy-in of the original prescriber, whether that's the family doctor or a specialist? And so with all of these questions, we initially started by publishing case reports to demonstrate how we did this for people. And I'll explain a little while later how this led into our next steps of developing deprescribing guidelines. So if we look at this particular patient, one might think that we're going to focus only on the benzodiazepine here. That's the one that jumps out, falls, fatigue, cognition problems. But here's the issue. The patient's actually taking more medications than that. And we need to look at the fact that cognitive impairment, falls are multifactorial in terms of causes. So if you look here, you see the lorazepam. Actually, I'll start here with metoprolol and telmisartan. He's been on these for about 15 years because he had a heart attack. No subsequent angina afterwards, but remains on them and is now having low blood pressure. He was started on lorazepam about 7 months ago to help with sleep, and then began experiencing more falls than he had been having previously, but also had his energy really reduced. This sort of contributed to poor mood. He got started on an antidepressant, which probably increased his risk of falls again. Started to develop some diarrhea, which could be contributed by several of these medications. That led to sort of challenges with function and being able to leave the house, et cetera. And so his mood was even lower. So we're trying to address deprescribing within this sort of milieu. And we're going to head next to our first question. I'll advance one here. And I think that I'm going to stop sharing so that Carlos can share the question, because we're kind of interested in finding out from you what you think you would like to address first for this 93-year-old man.
Okay. Dear colleagues, as you are all already used to our webinars, in our webinars, your engagement is very important. So one way of receiving your feedback is via your participation in our televoting. And I have already shared in the chat the link that allows you to access the televoting platform. And I would advise you to keep this link open in your browser, because during the webinar, we will have more televoting questions where you can participate. So please do answer through the televote. I believe that, okay, we are already receiving some answers, but our colleagues are not seeing the evolution of the answers. But let me check if it will work, because our colleagues are seeing only a black screen, but I believe that it will be now correct. But please answer in this link, okay? And other way of achieving and getting your participation is also via the chat that you see below the video window, the video streaming window. And you have the possibility to send your doubts, your questions, your comments, and they are very welcome. So please, let's engage. Let's interact. It will do our webinar more interesting. Okay, and the problem is solved. Our colleagues also see now the answers, and 80% of our colleagues say that they would do first ask the patient what he most wants to resolve or improve. Then 13% taper stop the lorazepam, and 7% taper stop the metoprolol. Okay, Barbara or Lisa, who wants to comment on this?
It's
answers?
me again.
Okay.
So I was really happy to see ask the patient what he wants to resolve.
I know. Look at all this person-centeredness here. This is amazing.
Yeah, this is great.
Yes.
And the patient, recall, was really frustrated by both the daytime fatigue, which gave him very little energy, and the diarrhea, which was making it challenging for him to even go out in public. So those are the things he wanted to solve first. So I'm going to, is it okay if I share my screen again?
Yes, of course.
I'm just going to show you the case report itself.
I would like to make a question while you are sharing the screen. Usually, what do you feel it's more difficult? It's to convince the physicians or to convince the patients?
In my practice, it's usually not hard to convince the physicians who work with me in the practice. And typically the family doctors or specialists who've referred patients to us are referring them because they know that we're going to look at the medications and make suggestions. So people are usually pretty open. And even when we have a specialist question, like let's say with the metoprolol for this patient, if the patient had a cardiologist and they were being followed routinely, we might send a written note to the cardiologist to say, in this particular case, actually the patient had sinus bradycardia, had never had any angina in 15 years. And of course, we also know more, I think a little bit better now, that beta blockers are not required post-MI in the absence of another indication for longer than say a year or two. So we would present that in a written format, and normally the specialists would just agree that we could taper and stop it. The patients, actually, I'm going to say they're actually pretty open to changes. I think partially because of the way we approach it with saying, like I always say, my job is to make sure your medications are working and not causing any problems.
Yes.
And then I say, what questions do you have about your medications? And almost always the patients say, do I need all these? And then I say, well, like we can look at which ones are more beneficial than others so that you can choose which ones you want to stay on. We can look at which ones might be causing side effects so that you can choose which ones you want to stay on. So I find that really helpful. Lisa, any other ideas?
Well, I would say that my experience very much varies by care setting. So working in acute care right now, where we have kind of a frequent changeover of physicians, it can be, we're always struggling, and I think this applies globally, with how long a patient has, their length of stay and the volumes and the pressure of who's waiting in the emergency room. So sometimes it's not a lack of willingness for our clinicians to necessarily want to do the deprescribing. It's about how much time and will this do to the length of stay. And so that's kind of a real pressure that we face, I think, in acute care, that possibly I'd be interested in the chat how many of you are kind of experiencing that as well.
Okay, thank you, Barbara.
All right, I'm going to go back and share my screen now. So you can see the same slide again. The questions, perfect. So in this particular case, I'm going to just try something here to see if I can quickly show you. Can you see this care plan?
Yes.
Or are you still seeing the PowerPoint?
Yes, we can see the care plan.
So here you can see, this is the actual publication of the case report. You can see that we were worried here and the patient was worried about the diarrhea. So what are the medications contributing to the diarrhea? Potentially the escitalopram, the pantoprazole, the telmisartan. Then we created an action plan sort of in collaboration with the patient around what we could reduce and stop and what we would what the patient and ourselves would monitor. Then we looked at the low blood pressure, the orthostatic hypotension and dizziness, the fact that the metoprolol might no longer be required, possibly telmisartan contributing. Then we looked at falls, daytime fatigue, and the fact that was contributed to lorazepam. So what I'm trying to illustrate here is there's these multiple drug-related problems, and there's these multiple plans, and then there's monitoring parameters that we add in here. We have had a lot of experience in the last 25 years in this practice, looking at how to do this and how to decide amongst all those choices what to do first. What I find when I do workshops, for example, with family doctors and pharmacists around polypharmacy and deprescribing, is they don't quite know how to come up with that plan. They don't know what to prioritize first. So when you want to make multiple medication changes, how do you decide what to stop, when to stop it, and how to stop it? And part of the problem is that no prescribing guidelines or therapeutic guidelines contain information about when to stop medications. For example, even the beta blocker post-MI, when are you supposed to stop that? And how do you do it? So this conversation began around 11 or 12 years ago with a group of colleagues talking about how the guidelines don't tell you when to stop a drug, and the fact that maybe what we needed were deprescribing guidelines. And that's how we came up with the idea. And we hoped that what we could do with these deprescribing guidelines is pull together evidence from different sources that would help people know when you were going to stop a drug, what would actually happen. Would symptoms come back? Would there be withdrawal? How severe would it be? When would it happen? How would they handle it? What they should monitor, when to start monitoring, when to stop monitoring, how often, and then, as I said, what to do if adverse drug withdrawal events occur. And so that was the kind of information we were trying to pull together into our deprescribing guidelines. So the first thing we did was start with a priority setting exercise, and we did 3 rounds with geriatric specialists across Canada to identify what people thought should be the priorities for a deprescribing guideline. And every single round, benzodiazepines came out on top. And I have to admit, I was quite frustrated by this because, in fact, a lot of the data on benzodiazepine withdrawal was published in 1990. So we've known for how many years? That's over 30 years. We've known how to taper and stop a benzodiazepine. That information is actually there in terms of what are the adverse drug withdrawal events you might see, how frequent are they, how severe are they, when do they start, when do they peak, when do they stop. That information is well documented, but it's not available, apparently, in a way that's sort of digestible, for people that's easy to follow and to use. So that, in fact, became one of our priority guidelines that we developed, along with proton pump inhibitors, because for that one, there actually were several deprescribing trials that we could easily summarize for a guideline. So that was sort of our test. And then we did atypical antipsychotics as our third one. This is the process that we used to develop the deprescribing guidelines. So we used a really rigorous method to summarize evidence on deprescribing for the different classes of medications and to develop guideline recommendations. And this whole process was guided by using GRADE and Agree To. And we have a paper if you're interested in reading more about the process. There's a link on this slide. And there's actually also a YouTube video on our website that you can watch about the development process. So it was, I just want to say here, it was quite rigorous. Lisa, I don't know if you want to comment on the development of the guidelines at all?
Well, I think one of the things that we originally balanced out was kind of, using our clinical expertise versus using this rigorous process, knowing that we had, limited resources and only so much time that we could put into this. And yet I think, as Barb will say, one of the reasons for kind of the international traction that we received on the guidelines is the rigor with which these guidelines were produced. And so that's a key point. The other thing that comes to mind is early meetings when we had that list in front of us and we were deciding which guideline to start with. And we were all a little bit reluctant on the benzodiazepines, not because there wasn't great information, but because we know that a lot of patients, particularly longstanding users, can be particularly kind of attached to their benzodiazepine. And so we really kind of debated where do we go first. And so I remember that clearly in our conversations as part of our deliberations. Not that we wouldn't do it, but just that maybe it wasn't our first one.
You have done an amazing work.
Thank you.
Really, really. And the pioneering work also.
Yeah, this is, I think, the first time that a deprescribing guideline has been developed with this level of rigor, although now there's a lot more information than even there was 10 years ago on guidance for deprescribing, not necessarily done with this level of rigor, but still pulling together valuable, consensus-based clinical experience with deprescribing. So there's a lot more available now than there was 10 years ago.
Don't steal our thunder. We're going to get there.
Yeah. we ended up producing 4 guidelines in our own team. So as I said, the PPIs, the benzodiazepines, antipsychotics, antihyperglycemics, and then a 5th guideline working with Emily Reeve in Australia, who many of you know, on acetylcholinesterase and inhibitors and memantine in dementia. So those are the 5 guidelines that we currently have. And there is ongoing work right now to develop one for statins and one for antihypertensives. And I think there's some preliminary work looking at one for antidepressants.
Yeah, I would also say the Australian group, sorry, Barb, to interrupt you. The Australian group has also just used similar methodology to produce an opioid deprescribing guideline as well.
Yes, we're going to have to add that to the slide. Next year, you'll see that one added on. Each of our guideline publications is published open access. Most of them are in Canadian Family Physician. The Australian one is on the dementia website in Australia. And they're very long, and they contain many tables and charts and evidence, etc. And I remember one of our co-developers saying, Barb, no one's ever going to read your guideline. You need to have a summary document. So we made these one-page algorithms that basically give the highlights of the different decision-making processes. And we'll go into those a little bit more next. So most people are familiar with these 5 algorithms, which are the summary of the guideline. We actually have an app that shows each of the algorithms, but links sections of the algorithm back live to the published guideline. So it acts as a kind of a bridge between the one-page guideline and the additional information that's in the guideline itself. So for our patient, this 93-year-old gentleman, the 2 that would apply for him are the PPI deprescribing algorithm. And I think you remember he'd been on pantoprazole, 40 milligrams twice a day for an NSAID-associated GI bleed 7 months ago. So we want to apply this guideline to that pantoprazole decision, particularly in light of the fact that the pantoprazole might be contributing to his problematic diarrhea. And then we also want to use the benzodiazepine deprescribing guideline for him. But what we don't have guidelines are what to do with his escitalopram, because we don't have an antidepressant deprescribing guideline yet, and his antihypertensives, the metoprolol and the telmisartan, again, which might be contributing to his orthostatic hypotension. So we have some guidelines, but we still need to practice without guidelines for some of the other decisions.
Barbara,
So,
I believe you are already answering a question that was made by Jane. She asks, in this patient, would you deprescribe only lorazepam or other medication also? For example, escitalopram.
Yes. So the answer is yes, we would deprescribe other medications. And I'm actually in a few minutes going to show you exactly what we did, all the different interventions we made.
Okay.
But that I think is a really, really important question, because sometimes people feel, or they might implement, say, the benzodiazepine deprescribing algorithm, and then it doesn't make any difference on fall risk. Well, it's because they haven't addressed any of the other potentially problematic medications. SSRIs actually increase fall risk more than benzodiazepines do. So that's important. And then all these antihypertensive agents, and this fellow had actually quite significant hypotension and orthostatic hypotension. So he never actually started with hypertension. He was just prescribed those meds post-MI rather than for hypertension. So he was quite dizzy when he was standing. So you have to look at all of those things and be very holistic in approaching the patient. And I'll show the example in just a second. I'll just go through the benzodiazepine deprescribing algorithm first. So for this particular fellow, he was taking the benzodiazepine simply because he had trouble sleeping about 7 months ago. So that's already taking it far longer than even a younger person should take it, which is typically considered to be 4 weeks maximum for insomnia. We put this part here about engaging patients because of the concern Lisa pointed out earlier with people really relying on their benzodiazepines. And that does often that's often the one drug that they're compliant with. So they don't want to let that one go. And so we added this component of engaging patients here early in the algorithm. And on the next page, actually, there's some suggestions for engaging patients and caregivers here, including a list of potential side effects, because what we found and other people have found is that alerting people to the potential or actual side effect, such as falls, memory problems, functional impairment, daytime sedation, motor vehicle accidents, even fractures, that people are more willing or interested in deprescribing if they know those things. And we've done some qualitative work with some of our patients that have shown that many people say, I never knew that this drug could cause these side effects. My doctor didn't tell me, my pharmacist didn't tell me. I didn't know that this was a problem. I assumed because it kept getting prescribed and refilled that it was safe. So the other thing we focus on is helping people understand, like, what would be the impact of stopping, what expected withdrawal would they see, and how could we make that easier. My light's just gone off because I haven't moved, and it's a motion sensor. There we go. Now you can see me again. All right. So our next step then, after the patient sort of agreed that yes, we could maybe look at reducing to the lowest effective dose, or seeing how they do by stopping it, is to taper. And you can see here that this is a strong recommendation from our systematic review using the GRADE approach. And that also offering CBT, if it's available, is a strong recommendation. There's monitoring advice here for withdrawal symptoms, but also for what are the expected benefits. And there's some good data that shows that within 6 months of stopping a benzodiazepine, you actually do improve cognition, alertness, daytime sedation, et cetera, and there's a reduced fall risk. So you can explain to people that these are the benefits that they'll likely see. And the withdrawal symptoms, what we tend to see usually in our practice, where people are primarily taking the benzo for insomnia, is some insomnia and sometimes some anxiety. Sometimes these other symptoms, but actually not that commonly. Most of these symptom information comes from work that Rickles and Schweitzer did in Yosanda Busto, published between 1986 and 1990, detailing side effects with benzodiazepine withdrawal, but the populations they were working with in those studies were people who had already had trouble getting off of benzodiazepine. So their incidence of adverse withdrawal effects was likely higher than the general population. And we have seen many patients that have no withdrawal effects or very minor insomnia that lasts, say, for a couple of days. And then there's some recommendations about what to do if they continue to have insomnia, and the importance of avoiding adding another sedative. And we've included, this is for Canadians, what drugs and doses are available in Canada. People who have modified this algorithm for use in other countries have just replaced this table with what's available in their country. And we have a few of those examples available. And we've included some information on CBT and behavioral management for insomnia, both in the context of primary care, and then also if someone's in an institution, how these steps for sleep hygiene make sense in institutional care. Very quickly, I'll just go over the next couple of slides. We took this information in the algorithm and we made a patient information pamphlet. It's more plain language than the algorithm. It's meant for the public. However, some people have said they still find it pretty text heavy to use. So there's a front and back page with an option to write out a personalized dose reduction strategy. And then we have an infographic that goes along with that. That can be a poster, say, that you could use in your pharmacy or your family practice to get people interested, to ask you the question about deprescribing.
Can you give us some examples of dose reductions? How do you handle it? And, maybe some concrete examples.
Yeah, so I'll show you in a sec. I'm just going to pop ahead 2 slides here. Because this is I'm sorry. No, that's okay. This is a good example. Actually, just to make sure I don't forget, these 2 slides, this video testimonial and the engaging people in deprescribing, these are helpful if you want to encourage someone to make a, to get involved in a conversation about deprescribing. This particular patient one, Jocelyn's story, this is a lady who was taking a benzodiazepine for anxiety for many, many years, like something like 30 years. And she tapered off her benzodiazepine over 6 months. And in this video, she talks about the experience and how much better she felt afterward. And so I have a lot of my patients watch that video. This video with Dr. Kevin Potty, he was actually Jocelyn's physician. So he talks about it from his perspective. So those are on our website. And then we've also included, if you want to take a quick picture of that, or we can later type them into the chat box. These are just ways to engage people in deprescribing conversations. So for this particular gentleman, it was around the fact that sometimes the risks of a drug, in this case, the lorazepam, outweigh the benefit. Now let's go to
just let me inform our colleagues that all these videos and all these tools that Barbara is sharing with us are available in the deprescribing.org website. I have already shared some of the links that were sent by Lisa. Okay. And the videos are also available there, and in YouTube you may find also the deprescribing.org YouTube channel where you can also watch the videos there. Okay.
Okay, so there were two questions that we're going to come back to now. One is, how much would you decrease or taper the benzodiazepine? The guideline that we developed recommends going by 25% intervals every couple of weeks and slowing that down towards the end of the taper schedule. Though that recommendation is taken from benzodiazepine deprescribing research studies. In our experience, the clinical experience of the guideline developers, the reviewers, the people who tested it, there were some clinicians and patients who said you could stop. If someone's just taking it for insomnia, you could stop it overnight. They might have trouble sleeping for a couple of nights and be feeling better within a week. Then we had other people say, oh, it will take 6 months to a year to stop the benzodiazepine. So it's very individual, and I think it really depends on someone's previous experience as well as the patient's comfort level. So we typically say to the patients, this is the medication we want to reduce. We want to do it slowly. We usually do changes every couple of weeks. How would you like to do it? And we get the patient involved in making the decision. So in this case, the patient went from 1 milligram to 0.5 milligrams, so a 50% reduction in week 1. 2 weeks later, we reduced the dose of lorazepam to 0.25 milligrams. So again, a 50% reduction from the 0.5. Continued that for 2 weeks and then stopped the lorazepam in week 7. So altogether, this took, 6 or 7 weeks to stop the benzodiazepine, the lorazepam. The other changes we were making were to start reducing the pantoprazole. We particularly in Ontario, we use rabeprazole instead because the lower dose is covered by our drug benefit program, whereas the lower dose of pantoprazole is not. But if the lower dose of pantoprazole is covered for you, you can use that. Then we also started decreasing the metoprolol dose to get at the other question about did we reduce other medications. So we started the metoprolol taper. We did try, for this particular patient was also on prednisone. Trying to remember the reason. Pemphigoid. I can't remember.
Bullous pemphigoid.
Bullous pemphigoid. There we go. In the end, we couldn't reduce the prednisone much, so I think we ended up going back to the regular dose. But you can see here in week 4, we started the escitalopram reduction. We continued reducing the rabeprazole and the metoprolol. Week 8, we stopped the metoprolol. We stopped the escitalopram. The lorazepam had already been stopped. Blood pressure was still low, so we reduced the telmisartan. He didn't like these silicone capsules, so we changed to the powder. Then we decreased the dose of telmisartan to 20 milligrams, and we stopped the rabeprazole. So overall, he went from 8 medications a day to 6 medications a day, but his diarrhea resolved. He was sleeping better. He had no daytime fatigue anymore, and his mood was better. And his blood pressure normalized, and he didn't have any angina or tachycardia from having stopped the metoprolol.
Okay.
So
I have 2 questions. May
Sure.
I, or later?
Yeah.
Okay. So Hannah is making the following question. Some psychiatry colleagues use other sedative medications, like, for example, trazodone, to use during the reduction of the benzodiazepine. What do you think about this strategy?
So there's no evidence that we're aware of where someone has done a study to show that trazodone reduces withdrawal effects or improves the cessation rate of benzodiazepine. So it's not an evidence-based decision. Sometimes it's a decision to want to give the patient something. We give the patient cognitive behavioral therapy for insomnia. We work with the patients. In fact, I'm taking a course on it right now, as is one of my physicians and one of my nurses, so that we can do a better job of providing that therapy. There are also a lot of resources that Lisa's going to talk about in a few minutes.
That is a great thing, because there is really good evidence with good quality that CBT works in the treatment of insomnia. The problem is that in most of the countries, for example, here in Europe, our patients don't have access to CBT.
Exactly. But there are a lot of books, and there are a lot of like online or
mobile apps. Yes. But by the way, in your case, in your reality and your daily work, who performs the CBT? Is it psychologists or other professionals?
So it's any of us, the psychologist. Well, it's not usually our psychologist, could be our social worker, our myself, our nurse, our physician. In Ontario right now, a lot of our primary care pharmacists are getting trained in CBTI to facilitate benzodiazepine and sedative deprescribing. The risks with adding trazodones, you're just adding another sedative medication, one that has some anticholinergic effect in addition. So you're just, you're not solving any problem by providing trazodone instead.
Yes, I agree. So I imagine you have good education programs about CBT, with good access for CBT education programs for health professionals.
I'm going to maybe let Lisa address
that. Well, actually, we're going to get to it in a moment. Actually, there's a resource that's available for kind of anyone wherever they are in the world. That's a series of modules. So if anybody is here and really interested, wants that training, we're gonna put it up here. It was developed by the Sleep Well group in collaboration with Queen's University. But Barbara, I'll let you finish this piece maybe, and then we'll go. I see that we're about halfway through our time today.
Yeah.
Okay, sure. Interesting. Thank you.
Okay. So we have another series of questions here that we wanted to ask you at this point. Just, I think some of these maybe have been answered, but just we'll see if there's anything jumping out that people want to have more information on. So I'll stop sharing and Carlos can post the questions.
Just a minute. I will activate a new televoting question. So please, colleagues, go to that link that I shared at the beginning of the webinar. And now I will share also the slide. Okay. So which of these frequently asked questions about benzodiazepine deprescribing is most important to you? Is it always that easy? What are the most common withdrawal reactions? Do the Z drugs need to be tapered? How long should tapering last? Will it help if I switch to a longer acting benzodiazepine? Am I failing if the patient doesn't stop the benzodiazepine? How do I avoid just changing the patient to another sedative? While we are waiting for the answers, we have another question from Maria. Is there a risk of excessive deprescription or harmful deprescription? Sometimes I am not sure if a patient should really stop a medication or not. This is from Maria. Do you want to comment?
Yeah, I can comment first, and Lisa, if you want to add anything. So that is one of the reasons why we identify clearly what needs to be monitored and how often to monitor, and then we make sure that that monitoring actually happens. So for example, if you're tapering furosemide, you want to go slowly, maybe by 10 milligram increments, and you want to be checking for ankle edema, shortness of breath, and having the patient weigh themselves, even if they don't have congestive heart failure, which we have had maybe 1 or 2 cases over the last 20 years where we've sort of unmasked CHF symptoms by stopping furosemide. So I think it's about going slowly, often one drug at a time, or if we're making changes, you saw from the previous example, there were some weeks where we made multiple changes. So we might have reduced the lorazepam and the pantoprazole the same week. Part of that is because they're affecting completely different systems. It's easy to monitor. We would not, for example, want to necessarily be reducing, say, 2 antidepressants at the same time, because then we wouldn't know which one had the effect. So it's, I think, going slowly, making sure the patient has bought in, monitoring carefully and frequently, being able to increase a dose if you have to. And then sometimes we use for drugs that don't have a lot of adverse drug withdrawal events where we can just stop them and see if the problem gets worse, we can do what we call pause and monitor. So we might do that, for example, with tamsulosin, we might pause for a week and monitor to see how they do, which I think also helps with patient buy-in, because then they're not stopping the medication, and patients pause their medications anyway, so they're pretty used to that concept. Lisa, do you want to add anything else there?
I think you've covered a large part of it, and okay. We'll talk about it a little bit after too, which is, and it kind of relates to the next question about, am I failing if the patient doesn't stop? Yeah. I think if there's an attempt and we've paused and we've monitored, and our monitoring shows us that it's time to come back, or to hold the course and either go longer and then hold, or then taper, all of that is okay. It's about being flexible and meeting your patient where they're at.
Yeah.
Okay.
Yeah.
I think that is important, because the prescription should not be a goal by itself. Our main concern should be the safety and the well-being of our patients. So sometimes we can go, 2 steps forward, but then 1 back, and if necessary, and then we can start a different approach another time and keep managing with time. So there are a lot of strategies that we family doctors can use, because we also have this precious thing that is called continuity of care.
And the patient's trust in you as well.
Yes, also, yes. So about these questions that we had in the poll, 25% answer, am I failing if the patient doesn't stop the benzodiazepine? Then we have a tie, 20% answer, how long should tapering last? And how do I avoid just changing the patient to another sedative? Your comments, please.
So I'll speak in the context of the day hospital experience. That top one, am I failing if the patient doesn't stop the benzodiazepine? No. We've had a lot of patients where we haven't been able to fully stop. Quite often we can get to the lowest effective dose. Every once in a while, we've had a patient where we've actually changed to a different benzodiazepine that had a different duration of action, and they had less daytime fatigue with that. We outlined that in a paper where we had done interviews with day hospital patients about benzodiazepine deprescribing. So I don't feel like I'm a failure if the patient doesn't completely stop. I do try to get to the lowest effective dose if we can. And because of our experience in knowing how much better people feel afterward, we do try to make sure that people are aware of that so that they know potentially to at least try. I think we talked about the question about how do you avoid just changing the patient to another sedative. And Lisa's going to talk about that with the CBTI resources, but there's also, we provide a lot of education around sleep patterns as people get older. But we also look at what medications might be causing problems with sleep. So caffeine is a big one. And we've actually had pretty good success with changing people from caffeinated coffee to decaf coffee. I did that myself, and I sleep about an extra hour every night now since I did that. The question about will it help if I switch to a longer acting benzodiazepine? This is recommended in Dr. Heather Ashton's manual. Many of you have heard of the Ashton manual from the UK, originally published in the early 1990s. And Dr. Ashton had a lot of experience with benzodiazepine withdrawal, particularly in people who were having difficulty. And she often used that technique of switching people to a long-acting benzodiazepine and then reducing and stopping it. However, the studies that have been done by Rickles and Schweitzer have demonstrated that using a long-acting benzodiazepine makes no difference compared to slowly tapering a fast-acting benzodiazepine in terms of the incidence or severity of withdrawal reactions. And so in particular, considering the fact that we're dealing with older people who are already falling and already have cognitive impairment, the last thing we would do is put them on a longer acting benzodiazepine. And then we've kind of addressed the tapering question that, typically we would try to do maybe initially at 50%, then 25% tapers over several weeks, taking advantage of the different dosage sizes and just getting smaller and smaller. And then you can potentially go every other night if you want. So there's a variety of different tapering strategies, but the most important thing is that the patient gets to design the strategy, and that the strategy does not include going back up a dose level, but if people can stay at the same dose, but we try to discourage going back up a dose level if we can. I would say yes, zopiclone, zolpidem, etc., also need to be tapered. There's no evidence that suggests that they don't. Although we don't have as much information about their adverse drug withdrawal events as we do about benzodiazepines, but I think we can assume they're fairly similar. So I'll go back to sharing my screen now, if that's okay.
Yes.
Oh, sorry.
Yeah, I think you were just going to close out there, Barb, with recommending some CBTI type resources that you've been using in your practice.
Yes, so this is these are the kinds of resources we recommend in our practice for patients. Quite often our patients are accompanied by their adult children or a spouse who will sometimes take the lead on this, but patients are coming to the day hospital twice a week for 8 to 10 weeks. So we do have time to introduce this kind of a program, and one of whoever has the time with the patient will take responsibility for moving them through that sort of program. This is the course, the Sleepwalk training course at Queen's University that several of my group are currently involved in. And then all of these resources can be found on the My Sleepwell website.
Is it a course for health professionals or for patients?
It's a course for health professionals, but Lisa, have you done it? I think patients.
I think a well-educated patient could. Yeah.
Yeah.
Okay.
Yeah. I don't think the literacy level was targeted, to be, the grade 5, 6 kind of reading level they talk about, but I think, a number of patients could.
So I'm going to hand it over to Lisa now, who's going to talk a lot about different resources available for deprescribing, and we'll go back and forth a little bit as we go forward.
Yeah, so we wanted to make sure that we added as much as possible to your deprescribing toolkits today. So I'm hoping that Barb's already introduced a lot of things, but I'm hoping I can at least show you one more that you haven't seen yet in terms of leaving today. The other part of what we'll do, depending on our time, is try and talk through some tips about deprescribing in particular care settings. So I may go through a little bit faster on this part, just because I think we've covered some of it already. So the first thing that we wanted to do is talk about steps in deprescribing. So there are a lot of articles that kind of talk about the steps, and we like to use this kind of framework because it really explicitly, to me, covers, the tapering, the monitoring for adverse drug withdrawal events, and documenting outcomes that I haven't necessarily seen in some of the other frameworks. So most of the frameworks talk about find your candidates for deprescribing in terms of identifying potentially inappropriate medications. They talk about making the deprescribing decision, but they don't necessarily go through what do you do then. The other piece that I sometimes see missing in some of the algorithms that I think is particularly important is that deprescribing requires a partnership between patients, their caregivers, and their clinicians. And so to me, that's where I struggle sometimes in acute care, because we do make decisions to stop medications, not necessarily in consultation. And so I think, to me, that isn't necessarily the spirit of what deprescribing is intended to be. So next slide, please.
Before we go, I just want to say it's incredibly hard to find a photo where the patient is talking and the healthcare provider is listening. So this is one of the only ones we could find.
That's very true. Yeah. This article is available open access. So Emily Reeve wrote this article, and it's actually a summary from 2020 of a number of tools and resources that are available to help with deprescribing. And so table 1 is what you want to see if you're going to look up this paper. It presents things in kind of 5 different categories about generic frameworks, guides and guidelines, decision support. Anyway, we'll go through them in a little bit more order, and hopefully I'll give you 1 or 2 more things you haven't seen. Next slide, please, Barb. So Barb has been through a lot of the tools and resources that we've had created at deprescribing.org. So our most popular by far are our algorithms, accompanied by the guidelines that actually fuel the algorithms. We have a tremendous number of patient pamphlets and infographics that are available in different styles. There's some of the guidelines have a decision support aid for patients to help make those deprescribing decisions. We also have whiteboard videos that show how you can apply the algorithms and the guidelines in different cases and contexts. Whiteboard videos that show how we created the guidelines in the first place. Barb showed you the testimonials that can be great for kind of talking about the benefits for deprescribing with different patients. We also have Barb and a colleague of ours, Wade Thompson, who also leads the deprescribing.org research team, created a module, an online learning module about polypharmacy and deprescribing. It's pictured there on the slide. And it's actually a fantastic resource when you need to orient a learner to these issues and you want to just here's something that you can take. It's case-based and it's there free of charge. All of the webinars that we've hosted on deprescribing.org are also on the slide. Barb mentioned our app, and I'll show it to you again in a few slides. And then please, we are, for as long as Twitter lasts, we're right now still on Twitter, tweeting about deprescribing issues, and then our YouTube channel as well. So those are some of our resources. Barb, next slide. And this is just a picture of our website. We've been putting the links into the chat. You know, we're so amazed kind of and grateful for the reach that this has had. So just to give you an example, between like March of 2022 and March 2023, we had nearly 85,000 unique visitors to our page. So we're kind of overwhelmed kind of by the traffic and the interest in this topic. So that's just to give you a sense of what our site looks like. We're in the middle of actually doing a big update. So stay tuned for that. I'm giving teasers, Barb. Next slide. This is a picture of the deprescribing app that Barb has already mentioned. It is available, again, free of charge. We are a channel on what's called the IAM medical guidelines, and it's pictured there. So all you have to do is go to the Apple or the Google Play stores, search IAM medical guidelines, and within that, once you've signed up, our deprescribing is a channel, and all of our guidelines have been, like our algorithms are there and visible. And as Barb says, they link to relevant content of our guidelines. So it's a nice way of kind of having that integrated information. And we're excited about the number of users that we've got going on that app and hoping to grow it now as we're moving forward. Next slide. Okay, these are not deprescribing.org materials, but Barb mentioned there's been like an explosion of resources. And so some of the ones that I refer to in my own practice are ones, these are both created from Australian groups, and they weren't compiled using the same kind of evidence review process that we used, but they are really still great for helping to design monitoring and tapering plans when you're deprescribing certain drugs. So those NSW resources were actually developed to support deprescribing in older hospital patients originally, and they have, I believe, 9 different topics like SSRIs and tricyclic antidepressants, anticholinergics for urinary incontinence. So those are great things that we don't have in terms of our guidelines as yet. The Tasmanian resources were actually created by a collaborative team of a geriatrician, a GP, and a pharmacist, and they have, I think, 13 different topics. So allopurinol and antihypertensives are there, as well as aspirin and bisphosphonates. There's many more, but this gives you a sense. Both sites also have some patient resources that you could tap into. And if anyone is caring for patients on hemodialysis here, there's actually also resources that have been created by the Stop Med HT team out of Canada that's linked on the slide. And they've created guidelines, or sorry, not guidelines, algorithms, consensus-based algorithms around how to deprescribe certain drug classes for patients on hemodialysis. Okay, next slide. Hopefully you've seen something you haven't seen before. So this is also, there's a ton of electronic decision support tools that are there. Some of the more common ones are Taper MD, MedStopper, and MedSafer are all Canadian based. There's also GMeds, which is very popular in Australia. They've been created for different purposes. The slide shows MedStopper, and that one we show because it's freely available online. And what you can do on the site is actually enter a medication list and say the indication for each drug, and it'll generate a plan that kind of talks to you about suggested stopping priorities. So it then gives you information kind of about the risks.
Can I make one or two comments about MedStopper?
Please.
The author of, or one of the authors of MedStopper website is James McCormack. He was with us in the webinar about the lipid guidelines, okay? So, and another comment is Jean-Pierre Jacquet. Hi, Jean-Pierre. He has written here in the chat, Stop and Start is a useful tool to deprescribe. I believe we all agree. And Jean-Pierre, in this tool, MedStopper, as you may see in the last column, the stop criteria are included in this MedStopper tool. And for our Portuguese colleagues, I may share also interesting information, because Luís Monteiro, our colleague, is a family doctor and also a PhD student, and is part of my research team. We have already contacted James McCormack, and we are already working with him in a Portuguese version of the MedStop, in a translation and the adaptation of the MedStopper for Portuguese. So we hope that in some months or few years, we will have a Portuguese version of the MedStopper.
Fantastic news. That's great to see that spreading. And I know Barb was a founder as well in terms of contributing with the effort on creating MedStopper. And so I know it's near and dear to her heart.
It's a very interesting tool. I wasn't aware that Barbara also participated in it. Once again, congratulations, Barbara.
James locked about 8 of us into a hotel room for 2 days. And we just like brainstormed and contributed all of our experience to putting this together. Dee Mangan was involved in this as well.
Okay, interesting.
There's always stories behind the story. We're doing a little bit of that today. It feels a bit podcasty almost in what we're doing today. But I think that's great and what we were trying to capture. So, I mean, the challenge with any of these softwares is clinicians always tell us they want it integrated into their existing electronic resources, which requires like resources. But then they tell me they don't want to be overwhelmed by alerts. So it's this interesting thing, but most of these are kind of, the prescriber can go and find this information. And I think they do certainly have a place in care. I wanted to, you mentioned stop, start, and that actually kind of leads to the next piece, which is like, how do I find these deprescribing targets? And so the next slide goes through kind of a thought process actually that I first saw from Dee Mangan, and it talks about kind of thinking about where to start. And so when we've got a medication list in front of us, one of the things that we often can do is first, let's think about why our patients are taking the medications. Can we actually pin down a reason for use for every medication? Often we can't. But then further, can we divide those into ones that are treating symptoms that we know the patient actually has, and ones that are being used for prevention of future illness? And the reason for classifying like that is because medications that aren't kind of accomplishing symptom treatment or preventing future illness aren't actually probably that useful. And so they may be offering little or no therapeutic benefit and may give you places to start. Kind of some no-brainer kind of examples are things like Docusate. Some people would argue ezetimibe is another one, and many of the vitamins and natural health products. So you can think about that, although often I find patients can be really reluctant to stop those natural health products. For preventative meds, really, this is about considering time to therapeutic benefit in relation to kind of your patient's remaining lifespan. So the classic example is a statin in an 85 or 95-year-old that's using it for primary prevention, particularly if they're then experiencing muscle aches. And then the third is to really, for medications where you can't, add them to either symptom prevention or symptom treatment, really thinking that process through. And so I think that's one framework that I found useful. The key too is that if your patient can be involved, they actually deserve to be involved in these decisions. So, as all of you have said, figure out what matters most to your patients, what medications might be involved. And those are offering really great places to kind of start your deprescribing journey. And I say it as a journey because hopefully, and particularly as family physicians, you've got the opportunity for longitudinal care. So the next slide just goes through some other resources of kind of like frequent hot topics for potentially inappropriate medications. So the AGS Beers criteria has recently been updated. The link is there and it's an open access publication. We'll talk a little bit more about anticholinergic burden. That one's particularly near and dear to Barb's heart, and is for good reason. The STOP criteria as well, developed by the Irish team, and then deprescribing. There's lots of deprescribing resources on this particular slide. This comes from a fantastic article that Barb led the authorship of with Dee Mangan in the American Family Physician. So if you want like a great overview topic, I love this one for learners in terms of places to go. Next slide. This is actually, so I had promised you that we were going to say a little bit more about anticholinergic burden. And in preparing for this talk, Barb and I were talking, and she was saying that, it's really interesting that, today we're talking about benzodiazepines, and lots of clinicians think that's a big problem. And yet anticholinergic is likely even more important in terms of affecting cognition, its impact on falls. And so this is a tool from, you're going to be like, whoa, what is this? This is actually a table from a group called RX Files in Saskatchewan, Canada. And they offer really comprehensive medication information. So it's kind of like the pharmacist like gold toolkit that we all hold around in Canada. And so they have a great manual that's called Jerry RX Files that has a lot of great information for caring for older adults. But they also have an online service that you can subscribe to, or you can buy print copies of their tables. And so this is actually like a really neat list of like all sorts of anticholinergic medications rated by kind of how strong they are in terms of their anticholinergic effects. So the different colors, blue is low, red is moderate to high. And it gives you kind of a great quick reference about like, well, what are my top ones? The next slide is another resource for talking about working out anticholinergic burden in your patient. And what you can do in this one at the ACB calculator is actually plug the patient's medications into an online tool, and you can get kind of a score about their anticholinergic burden, or you can actually look, they have a list too of sites with a list of individual agents with their anticholinergic scores as well. So I find these useful. Barb, did you want to say more about anticholinergic burden?
Yeah, I think just to pick up on what you said is that we often jump to the benzodiazepine as being the big problem for patients in terms of confusion. But we have actually seen a number of patients where we have reduced their anticholinergic burden significantly by tapering and stopping their amitriptyline, imipramine. Even drugs like trazodone and citalopram, you can see here, are contributing somewhat to the anticholinergic burden. So we reduce that burden overall, and we have had patients who have had their diagnosis of dementia reversed. So it also looking at side effects of anticholinergics like dry mouth and constipation, things that make people's lives really uncomfortable. We have managed to eliminate those problems for patients. So a focus on anticholinergic burden, I think, is really, really important going forward, not just benzodiazepines.
Yeah, that's great. Thank you. So the next part is we've talked, I've already kind of tried to convey this, and I think this group is well aligned in this vision that deprescribing is really a journey about partnering with patients. And so sometimes I worked for primary care for 10 years, and sometimes I heard that time was an issue, or not being sure how to have a conversation or raise this was an issue with patients. And so the next slide goes through kind of a nice framework that integrates deprescribing and shared decision making, which is really kind of the global emphasis on shared decision making is growing, I think. And I like this framework because it's a simple one that can be used to really guide deep prescribing conversation. And essentially what it talks about is 4 steps. So the first thing is really to create awareness that options for deep prescribing exist. And Barb in an earlier slide said like had those thought bubbles about how to create conversations. Those are all great conversation starters that you could use. The second step is really to discuss options and potential benefits and harms of each medication. Then to explore preferences for different options, and finally to make a decision together. So when we break it down into these pieces, hopefully it may not seem as overwhelming, although can be time consuming. Now, interestingly, when talking about shared decision making for deep prescribing, we have a colleague, Christy Weir, now in Europe via Australia, who did an interesting study that she found that people kind of fit into one of 3 categories around their preferences for shared decision making. So you've got the group that wants to be totally involved with every step in this process. You've got another group that wants to know that they have choices and be aware of options, but ultimately they're going to let health professionals decide. And third is people that don't actually want to be involved at all. They're just like, please, physician, do it for me, or care team. So to me, actually, when I try and think about how I'm going to frame my conversations, my first mission is to try and figure out who of those typologies I have in front of me. So I want to create awareness that the options exist and then kind of feel them out for how much more they want to go before I head further down the path. And I don't know if that would save anybody else time, but it saves me sometimes, and trying to keep in mind who I might think about. Now, the one trick on that is it can vary by medication and also by kind of their state of readiness and how well they're feeling. So I often see people in the hospital and one day they're like, no, don't talk to me. And the next day they want to talk to me. So it can vary a little bit, but that's something that I found helpful. Next slide just goes through some more patient information resources that we have at deprescribing.org. And another one more slide talks about, Barb and I are both members of the Canadian Medication Appropriateness and Deprescribing Network. And this is a Canadian group, but actually internationally, there's been like an explosion of deprescribing networks. So Australia, England, the US, there's lots more. This is the Canadian Medication Appropriateness and Deprescribing Network has had a particular emphasis on public education. And so I find them to have like really nicely designed resources for like waiting rooms and like videos that you could play to try and stimulate people to ask you about deprescribing. We know that sometimes clinicians find it easier when the patient raises the question or the patient books in for that reason, rather than trying to tack it on to the end of a primary care visit. So I would encourage you to check out their site as well. And then just finally, in terms of bringing it home about kind of general deprescribing pieces, I said earlier that I like that framework because of the tapering, monitoring, the documenting. And this is really like a piece that is so important, particularly for me in acute care, as we try and transfer people out across care settings. I can't finish the deprescribing myself. I'm often having to transfer responsibility for that. So me writing specifics about who is doing what and when, what I suggest for tapering, monitoring, follow-up, and including, what to monitor for, has actually been said to be quite helpful by my primary care colleagues. We talked earlier about, you haven't failed if the patient hasn't stopped that benzodiazepine. Like, we do all have to adapt. So being flexible and really making sure, the best deprescribing is going to happen when we're all on the same page. So communicating that across. And these are kind of pearls that we've developed over time. Is really about developing and communicating a plan. This next slide just talks about back to anticholinergics and shows you another example from that GeriRx files. This is really handy when you're creating your tapering and monitoring plans, because it goes through common withdrawal symptoms and actually even a suggested approach for tapering. So Barb, I don't know if you want to say more about this one, but I think this is quite useful for anticholinergics.
Yeah, I don't think I need to add to that.
Okay.
Point.
Yeah, no problem. And the next slide is just actually, and Barb already kind of showed us with the benzodiazepine example, our algorithms for deprescribing were actually they were co-designed actually with clinicians. So what happened is we created them, and Barb and the team went to several different clinicians and all sorts of stakeholders and asked for their feedback about what information do they need. And so these were developed iteratively over time to really try and answer the questions that clinicians asked. And so what's great about them is they include, I think, uniquely more information about tapering and what to monitor for than I've seen in other guides. And so I really encourage people to look at those for the classes that we have, both the front and the back side. You'll see this is just the front sides of the ones we have, but I think it's a great resource. So that was, hopefully I've added to your kit. And now we'll talk a little bit more about care settings in our remaining 10 minutes or so.
Yeah, so
Okay.
we know that people on the call are coming in from a variety of different care sites. And so we thought the next question would be to find out where you are, what setting you're interested in hearing a little bit more about. And then we have a few slides
Okay.
about that. Carlos, do we have time to do this?
Yes, we do. I have
Okay, I'm gonna
already
stop
shared
sharing.
here. Okay, the question, and our colleagues are already answering.
Okay.
To a
Awesome.
new poll. Meanwhile, I have here a question from Lucas. Lucas is from Poland. Hi, Lucas. You gave the information that statins are one of the most frequent drugs that we should withdraw. What are the indications?
Yeah, so I don't want to leave you with that impression. We're actually working on a statin deprescribing guideline at the moment, and our systematic review, like, I don't want to spoil it, is actually showing that we will have a recommendation for statin deprescribing, but it may not be as extensive as everyone thinks. The example was from me trying to communicate that in a primary prevention, I might consider deprescribing a statin, particularly if somebody's having an adverse effect, or if I really do think that, you know, they're in a position where they're not able to take it anymore. So I use the example of the 95-year-old who is extremely frail, who may be having a side effect from it as a reason for deprescribing. But actually, stay tuned for statin deprescribing. Barb, I don't know if you want to add to that in your own practice, but
Yeah, no, we would look again, we're looking at, are people having adverse effects, and it's always weighing the benefit versus the risk. Time to benefit, what is their baseline risk, et cetera. So it's not an easy decision to make, and certainly not one you would make across the board.
Okay.
We do often find it helpful to do a pause and monitor if someone's having muscle pain and weakness.
Okay.
Carlos?
Another question from Joshua. Is daytime fatigue the most common side effect of benzodiazepines?
I would say we commonly see that. I think people don't realize that the benzodiazepine doesn't stop working at 8 o'clock in the morning. When you get out of bed, it continues to sedate you over time. So yeah, we do see a lot of just fatigue, daytime sedation, inability to concentrate. I remember one lady who, within about 6 or 7 weeks of stopping her benzodiazepine, was able to play cards again, because she couldn't manage the number sorting that needed to be done with card playing. So yeah, that effect on concentration and such is noticeable for sure. Okay,
thank you. You may share your slides again.
All right. I just want to say that poor lady thought she was.
And 100% of our colleagues work in family medicine or general practice office.
All right, we can tailor our comments. Yes, that's great.
All right. So we've got a few slides left. Then I'm going to talk a little broadly, because I think this Lone Institute National Action Plan from the US kind of applies across all care settings, but really I look at these and I think primary care, regular prescription checkups, particularly for older people, raising awareness amongst the public and even with our students, et cetera, around medication overload, improving information that we give them at the point of care. And that might even be learning to say learning to change the wording that we use when we initially prescribe a medication. So avoiding saying you need this drug, you will be on this the rest of your life. Introducing the idea that with a variety of medications, they're temporary. They're to get over a problem, and then what's the exit plan? So maybe it's the first episode of depression. Is it something they need, and the antidepressant something they need for the rest of their life? Or should you at the outset give them some information about the expected duration of treatment, and then what the exit plan might be, say, a year from now? So that, I think, is very applicable to primary care. And then the importance of educating and training healthcare professionals. And we've actually, at the Canadian Deprescribing Network, just published a curriculum paper that can be used in medical school, pharmacy school, and nursing school to identify gaps where deprescribing could be introduced into curricula. So when I get a minute, I'll pop that into the box. And then this is more, well, it's policy, institutional, but also in primary care is reducing the influence of industry. So maybe developing policies around whether or not you will accept pharmaceutical representatives in the practice as an example. Just a couple more here. These are some lessons from the Institute for Healthcare Improvement. They actually, in the US, partnered with several large health systems to implement our deprescribing.org tools across their different sites. And they've come up with a variety of recommendations at different levels, the health system level, the patient care team level, the public level. And it's really, I think, their recommendations, which you can read more in detail about on their website, really, I think, focus on trying to come together to create this cultural shift to deprescribing across an organization or a team. The next slide just gives some examples of projects here in Canada. On the right-hand side, you just see a poster that a group in a community pharmacy used where we were trying to implement the deprescribing guidelines in a series of community pharmacies to look at the feasibility of doing that. And they found that this poster attracted a lot of people who came up and said, what's a PPI? What's a proton pump inhibitor? Am I taking one of those? Then they booked appointments with the pharmacist who had a discussion. And then if there was a recommendation, they would get the family doctor involved and send a recommendation. Similarly, for the on the top left-hand corner, there's a group called Safer Meds Newfoundland, and they're looking at trying to reduce benzodiazepine and PPI use in one of our provinces that has high use of both of those drugs. And they've incorporated both a public education program and also a community pharmacy family practice intervention that focuses on helping people make those decisions about stopping medications. And just, I was going to pass back to Lisa now to talk about the next couple of slides.
Sure. So yeah, because we have the majority of kind of family medicine GP office people here today. We wanted to mention a couple of things. So first, Choosing Wisely Canada has created toolkits, and they talk about an approach in their Bye Bye PPI toolkit that you can access at the link on the slide here around how you can do this at a population level. So one, we've talked a lot today about like kind of the individual person in front of you and how do you assess their medications for what's needed and what's not, and what is a deprescribing candidate. Another approach that we've seen, particularly when I used to work in primary care, was around thinking about population health and how we can leverage tools like electronic medical records to really identify groups of patients who might benefit from an intervention. And so this is an example that they include in their toolkit for proton pump inhibitors, but we've done it across actually several classes of medications in my practice experience, where we search the EMR for people that are using the medication. We may go into the charts to think through, does that medication warranted or not, or we may use a more blanket approach where we bring them in for a conversation and determine that in the process of that conversation. And so I think this is really the intention of this slide, is to really tap into the fact that you can use technology to help you with your deprescribing efforts, and then think through in your practice, what's the best way for having those conversations. There's been studies where people have been, identified through an electronic record and mailed a pamphlet, and then offered, we've tried that with mailed a pamphlet and offered an opportunity for a conversation. Sometimes they're high yield and sometimes they're not, but it's a great way of kind of trying to bring new people into the conversation. And so there's different tools and resources that can be used. So that's one kind of population level tip that we have. I don't think we need to go through the deprescribing in hospitals necessarily today, because we don't have that audience with us. There's some tips kind of over time, but it's really about thinking through, standard order sets and the opportunity. We know in hospitals, we start medications in a particular unit like intensive care actually, and then we don't stop them when we get them to the floors, and then we don't stop them when we discharge them home. And so those are high risk times in terms of care transitions for really thinking through deprescribing. I think that's probably all I need to say about it for that. And this was just an example with our PPI deprescribing algorithm. I was going to share a little case about how that happens, but I don't think we need to for today. What we'll do is we'll go to the next slide, which is talking about, so I've I think probably like drilled into you now about patients being the center of a deprescribing effort and the importance of having these conversations. And so one of the things that we did in one of our studies was we were doing a community outreach project where we engaged with the public to ask them, what do they need to have better conversations about deprescribing? And they said training. So what we did is we worked with them to create actually a workshop series where we have teach them about how to have conversations and talk about their medications with healthcare providers. And so this is a three session workshop series that we created, and they were refined kind of over several iterations, and we've customized them. We originally started for the general public, and then we customized them kind of for people working in caregivers in long-term care. But all of these, we're not currently offering these workshops ourselves, so we were facilitating them at one point, but all of the materials and resources are available online. So if you have a passion that you want to help people have conversations, all of these resources are there, and we would encourage people to use them. They're there. So just in terms of closing our formal conversation, and then we'll have a little bit of time for questions, is we really like to end kind of by coming back to just reminding everyone about the importance of this work. And so on our deprescribing.org team, we really do envision a world where people and health providers work together to decide if, when, and how to reduce or stop medications. And we do this in two ways. So we create guidelines and tools to support deprescribing. And then we're doing things like we do today, which is trying to help people to use them. And we do all of this really because our goal is to maximize people's capability, opportunity, and their motivation for deprescribing, really to improve the well-being of older adults. And so on behalf of Barb and I and the rest of the team, it's that goal that kind of keeps us going. And we know many of you are here in your evening hours, so we think that you're like-minded, and we thank you for taking time from your schedules to join us.
Thank you.
That was kind of our formal close.
It was really, really interesting. Lisa, Barbara, imagine I am 80 years old lady taking a benzodiazepine since the 90s, 80s. It was so used then, and I take it for over more than 30 years. And look, doctor, I just cannot sleep without this pill. What would you say to me?
That sounds like about 90% of my patients. And
Okay.
what I find is that when they say I can't sleep without it, it's because they tried to stop it and they didn't sleep for one night. And so they assumed they needed it and they started it again. And so
Well,
there's
doctor, well, doctor.
Okay.
There was a week where I went on holiday and I forgot the pills. So I didn't have them. And during that week, I could not sleep. And it was horrible. I felt really, really bad. So I don't think I can live without it. I am a difficult patient.
Okay, so I would probably ask this patient, I'm going to ask you then, while you were on holiday, tell me about how your meals and drinking changed. For example, did you have more coffee or tea than usual? Or were you having a glass of wine with supper?
Well, yes, I used to a glass wine with supper and coffee in the morning.
Mm-hmm. And were you doing that on your
doctor,
vacation?
I was relaxed. It was really a good time.
Yeah.
But at the evening, I just couldn't sleep. You know,
Yeah. So there could be a lot of things contributing to not sleeping.
Okay.
Certainly caffeine can make it very difficult to sleep. I always know that if I have a drink of wine or a beer or something at supper, that I will wake up during the night because those kinds of drinks are stimulants. Now that you're back at home and you're not necessarily having the drink every night, it might be reasonable to see if we could maybe reduce the dose a little bit. The reason that I say that is that in your situation, you completely stopped taking it sort of cold turkey for a week.
Yes, it's true. That's true.
Yes, and I find people are able to stop it a little more easily, or even reduce
Okay.
to the lowest
And
effective dose if they go very
do
slowly.
you think it would be a benefit for me by reducing a dose a little bit?
Yeah, so I think to look at the benefit, we have to look at, is it causing any side effects for you?
Mhm.
So tell me about your sleep right now and how you feel during the daytime.
Well, I used to sleep about 5 to 6 hours when I take the pill. And in my daytime, sometimes after lunch, I feel somehow sleepy. Otherwise, I feel okay, yes.
Okay.
And
Okay.
it depends on the weather also. And, you know,
Yes.
sometimes when
Yes.
weather changes, I don't feel so well.
Yeah. Yeah. So it's possible that the sedative might still be causing some sedation the next afternoon. That might be this is hard to do, Carlos, because you don't look like an 80-year-old woman. And
And you weren't referred for falls, and you weren't referred for
But
yeah.
broken
So
hip
I
in the
guess
hospital.
that's the other thing we would look at is,
but
have
you are
had
doing
any
great.
falls?
You are doing great. I believe
Okay.
you are doing great.
Have you had any problems with falls?
Oh, yes, I did. Yes, 1 month ago, I have a fall,
Okay.
and it was bad. I hurt my knee.
Okay. Okay. So it would be good for me. I would look at your whole list of medications and see if there's any medications that might be contributing to the falls.
Mhm. Okay.
And then what I can do is make some suggestions to consider around what we might reduce to see if we can reduce the risk of having a fall. Would that be helpful?
Yes, I believe so. Yes.
Okay. Okay. And I can get some information for you because you asked about, are there any problems with taking sleeping pill? I can get you some information we can go over together on sleeping pills that will help, I think, look at like what's the benefit, what's the risk or the side effects. And then if you want to reduce the dose, how do you do that so that you don't have problems sleeping?
Okay. Okay. That sounds great to me.
So I'm realizing as I'm talking to Carlos, my initial reaction was to tell him that, or tell her that we wanted to stop that benzodiazepine. And then I pulled back and I started to approach it the way I normally would do in practice, which is really about gathering information and then asking, would it be okay if I provide this additional information? And then because people need to think about it.
Yes, yes.
So,
I believe it was a great example and a
good.
great dialogue.
That's good. You sort of threw me off a little there.
He gave you the run for your money. Yeah.
Actually, the idea of making this kind of simulation was from when I heard Lisa telling that the training was relevant.
Yeah.
I thought, well, let's train.
Yeah.
I'm sorry, Barbara, because we didn't have that prepared before.
That's okay. I just, my light's gone out again.
She stopped moving.
Okay, I have one question from our colleagues from Jan. Have you ever faced critics by some specialties related to the prescription and the prescription guidelines and so?
Lisa, do you want to talk about how we got the buy-in of those folks early on?
Yeah, I think there was a lot of strategy very early on in terms of bringing everybody with a stake in this game to the table. And so right from the beginning, we said, what specialties are typically involved in prescribing this group of medication? And let's find someone who will work with us all the way through from the beginning of kind of figuring out the scope of the guideline all the way through this process to help that. And the real idea was around having someone who could champion and be an opinion leader within their specialty, but also represent the concerns that specialty might raise. And so I think that was one of the real strengths of our process in terms of how we engaged people all the way through. The other piece is that they were very strategic about like sending the guidelines for endorsement and review to almost every association you could think of, including several that represented specialists, to get their feedback, to have them review the document. And they sent sometimes some really good comments that needed addressing. And so all of that got included in terms of the guidelines, which I think really strengthened the product. Barb, have I missed anything? What else you guys did? It was brilliant.
The other thing that comes to the top of mind is when we were looking for guideline development team members, we were not only looking for specialists who could represent their specialty and maybe their organization, but we also specifically looked for people who were involved in the Cochrane collaboration. So for example, the chair of the GI Cochrane group was a member of our deprescribing guideline for PPIs. So again, we were trying to bring in the specialist, but also that reputation and the knowledge with the Cochrane group to the guideline development. And then I think, as Lisa said, like getting feedback, like sending out the guideline to all these different organizations. And then we created very detailed response documents. So it was ultimately relatively easy to get them to officially endorse the guidelines.
You have done an amazing work. Maria Rosario Gonçalves writes, thanks a lot. What a nice webinar and the role play. Thank you.
Barb's going to want a do-over though.
That was a last minute surprise. Rosario Falanga, thanks Carlos, Barbara and Lisa, great work. Paco Camareles, thanks, very good webinar. John, this webinar was really useful. Thank you very much. Filipa Santos, great work. Thank you very much. Anna, thank you very much for your presentation. Barbara and Lisa, congratulations for your work. Sabina, this was great, really relevant for my clinical practice. Thank you. So I believe our colleagues enjoyed a lot. Mariana Leitão, thank you for this webinar. It's a very important topic in our practice, and it was very helpful to hear Lisa and Barbara. Congratulations and thank you so much. I will give you now the word for you to say goodbye to our colleagues.
Oh, thanks. Well, thanks a lot, Carlos. This was really fun. And despite the stress of the case, at the end there,
I'm sorry.
I'm still like, I'm okay. I really appreciate the opportunity anytime to get to talk to people about this topic. It's one I'm extremely passionate about, and it makes me really happy that so many people are interested in hearing about it.
We had colleagues from all over the world, you know, even a colleague from,
it would be great if we could get like a list, not
even a colleague from Bangladesh. Even a colleague from Bangladesh.
Love to know the countries. Yeah, that's phenomenal in terms of and just thanks to everyone for the chance to kind of share the work, and of course to see Barb sweat. I'm kidding. Barb's unflappable most of the time.
Barbara, do you need some CBT for the next webinar?
Actually, I might need a glass of wine.
Wine.
Okay. But we are still receiving some more comments from Jose from Spain. Excellent as usual. We have learned a lot. Lucas, very interesting topic and webinar. Hassan Kabir, thanks for these arrangements. So
that's really nice.
Okay. Thanks again.
Thank you both, and have a nice rest of your day, a nice afternoon for you both.
And wishing a good sleep to everyone in Europe, right?
Yes.
And dear colleagues, our next EUROPREV webinar will be an extra module that was planned at the beginning of the year, but then when we have done the first webinar, we received a lot of questions related to overdiagnosis, and then we decided to do an extra webinar related only with this topic about overdiagnosis. We will have Alexandra Jonsson and John Broderson with us. It will be on next week, 24th of May. So see you then. Bye-bye. Have a nice